Okay, I think we are on. Hi, so we're going to talk about anxiety and phobia. And I told you, some people have a height phobia, and yes, but not when I'm in an airplane. So we're good. So my phobia is going to be under control. I hope you enjoy the background as we talk about anxiety. So let me share my screen with you. Okay, anxiety disorders. This is something we've talked about today. Um, and you had a quiz over. So use this as something that you can for the final. So anxiety we spoke about in class as being some feelings that are so high, anxiety being so high that it interferes with daily functioning. That's when it becomes a true psychopathy. And as you understand from class, there are several ways that anxiety can manifest. So we'll just move on and talk about that. Again, the epidemiology, there's a lot of people who say it comes from a lot of different sources. You're welcome to look about these room statistics of that, of anxiety disorders. Some people think it has to do with the excitatory neurotransmitters, the GABAs, and things like that, norepinephrine. Nobody knows for sure, they just think that. So general treatment for anxiety, keeping them calm, so calm environment, assisting them understanding when they are anxious, make them more aware of when they're anxious. Sometimes music helps people and medications. Some people exercise. Basically, reassurance helps to have people relax and ground themselves to get away from those anxious feelings. So anxiety and stress model. Anxiety is that feeling of discomfort that comes, it really doesn't have a rational cause. There really isn't a fear associated with it. But they could be perceived threats to physical or psychosocial integrity or your needs. It has 4 levels of degrees: mild, moderate, severe, and panic. And when you're increasing in those degrees, you tend to either, Hans Selye says you learn to cope or adapt, or you have exhaustion or you maladapt. And maladaptive, we spoke in class, are things that are just not healthy for your body to be doing. Okay. Physical responses of anxiety, and this is usually moderate, severe, and panic level, or your physical responses, your psychosocial, not psychosocial, your physiological fight or flight. So elevations in blood pressure, pulse, and respirations, the whole norepinephrine release with the dilated pupils, the cold, clammy skin, constipation, urinary frequency after a period of urinary hesitancy, hyperventilation, restlessness, lack of coordination, agitation, basically in aimless kind of movements. Cognitive responses to anxiety can be impaired attention and poor concentration, being forgetful. Again, these are moderate, severe, and panic levels of anxiety, because we do want to have that mild level of anxiety. A mild level of anxiety increases our perceptual field and makes us more apt to be effective problem solvers. As we move towards panic and panic disorder, we see our perceptual fields becoming more and more narrow. And mild anxiety, what you need for test taking in stressful situations that you have to be in control of. It's because your perceptual field is heightened, you're capable of bringing in a lot more and making better decisions, better judgment calls. You understand what's going on. You can identify a way out of the situation, working towards that goal, either directly or through alternatives. It may be a little uncomfortable for you, but it is still something that you can handle. Some people get into the automatisms with with their fingernails or with the pencil tapping or shaking the leg for mild anxiety. But you see that plus the increase in the shrillness of the voice leading into moderate anxiety, and then from moderate into panic. or severe anxiety and then panic. So what do we do for mild anxiety? Well, we talk to them. We help them and to solve their problems, and we can teach with mild anxiety. We can help them figure out how to control themselves. It's difficult to do, almost impossible to do in moderate anxiety, but in mild anxiety, it's something we can still control the narrative on. Now, here's some different relaxation techniques that you can help your patients: breathing exercises, nutrition, biofeedback, excuse me, oh, meditation, excuse me, support groups. Support groups for anxiety are always a good thing. Other coping techniques, deep breathing, meditation, mental imagery, biofeedback. Some people use aromatherapy, setting goals that helps, pet therapies, reflexology, bubble therapy, like that one. Moderate anxiety is a step up in that fight or flight. You have more inattention. Things have to be pointed out to you. This is where on the test questions, you tend to miss that one word that's crucible that changes the answer that you would select. You can't really problem solve very well. You need a lot of guidance. Concentration is very difficult, and you start seeing those somatic complaints, so headaches, stomach aches, that go along with it. So what do we do for moderate anxiety? Same as for mild. Again, teaching in this level is going to be very difficult, but they still do have some ability to focus on what you're saying if you're in the right position, like directly in front of them to talk to them and help them to solve their problems. Severe anxiety, they aren't going to be teachable. The perceptual field is greatly reduced. Attention's all over the board. They're very all about themselves, survival. They cannot attend to events. They're fearful even. They think everybody's out to get them possibly. There's just this sense of doom, and it's high levels of the norepinephrine response. So we had to take them away from where they're at, put them into a calmer milieu, whether it be their own bedroom or their own hospital room, or just basically away from all the chaos. Very simple instructions for them to follow you, get them to sit down. And you might want to use some anti-anxiety meds or some benzodiazepines, antipsychotic medication, possibly, to calm them down. And then we have panic. Panic level and panic disorder are pretty much the same signs and symptoms, the difference being panic level in the elevation of anxiety is the pinnacle. I mean, it is the most anxious, and it grows gradually. If it is panic disorder here, is a sudden onset of extreme panic. It is no sooner than 30 minutes. It's that quick it comes on. It's very discrete episodes, panic attacks. It's a bad thing. So if, according to the DSM-5, panic attacks are diagnosed when the person has recurrent, unexpected panic attacks followed by at least 1 month of persistent concern or worry about future attacks, or their meaning and a significant behavioral change related to them. So the strict avoidance, somebody who really doesn't do well with the outside and with other people may become agoraphobic, where they don't leave their home because of panic disorder. It causes that kind of a situation. And that happens. Panic disorder is really not, it's sad. It's not a good diagnosis, especially when it accompanies agoraphobia or other situations, abuse, domestic violence, things like that. Panic level anxiety, again, very much like panic level disorder, they can't focus on anything. They have emotional paralysis. They may have some psychotic features with delusions and hallucinations. They may not be able to speak, very unorganized thinking, and usually they don't sleep very well. So what do? Well, we take them to a calm milieu. get them out of the big area. You have to be right directly in front of them, but not too close where they're gonna hit you. Gotta medicate or restrain. So restraint, seclusion, again, seclusion, they could still do damage to themselves. So I might be more apt to restrain than seclude a patient who's experiencing panic level anxiety. It's just basically provider discussion. So maintain calm manner about yourself. Stay with client. Simple statements to them in direction with a very low pitched voice, even metered breathing. You want them to mirror that. I know we've talked about the person in crisis. It's very similar to that, these interventions. You want to be very calm, very in control, because they're looking for control. Listen for themes. Sometimes they will tell you what's bothering them. You know, if I were on top of the Ferris wheel, you know, I'd be screaming about, get me down, I'm gonna fall, something along those lines. And I may say it again and again and again. But those are things that you need to listen for. Meet the physical needs that they have, but set limits. Somebody who's a panic level might try to run off and, you know, jump off a building to get away from something. So you got to make sure that they're safe. And you may need medication, seclusion, or restraint. Different types of anti-anxiety or anxiolytics with benzodiazepines. We have antihistamines, non-benzodiazepines, beta blockers, and antidepressants. Okay. The big benzodiazepines, you got to worry about those guys. They are really addictive. I think Valium, I think Xanax. These are not something that you want someone using on a regular and routine basis to control their anxiety. Phobias, type of anxiety, persistent, irrational fear of an object, activity, or situation, which leads to avoidance. Now, with phobias, the big treatment there is systematic desensitization, where you bring them almost up to the edge of dealing with their phobia and then back them up and then bring them close again and then back them up and then bring them close again. Like if I were to try and get over the fear of heights, you know, and writing the Wheel of Death, I may write it up so far. If somebody was willing to work with me and bring me back down again, and then I would go up to the next level and they could bring me back down again. So it kind of, that systematic desensitization is what works best for treatment of phobias. Some people prefer flooding. Flooding is like that TV show. They say, what are you afraid of? And the TV show person says, I'm afraid of snakes, or I'm afraid of being buried alive. And so then they do that to you. That's flooding. Like if you're afraid of being buried alive, they will bury you alive. I don't know if you guys remember that TV show, but it was pretty scary. But that's a therapeutic technique. It's called flooding. I don't know that it works as well as systematic desensitization. Literature still supports it as a valid method of treatment. But like I said, I'm a little more kinder and gentler than those types of therapists that just kind of want to make you face reality right now. So anyway, with phobias, irrational fears over something that's just not something you should be afraid of. OCD, we kind of talked a little bit about obsessions and compulsions today in class. Compulsions is something we have to do related to the obsession. Compulsions can get extremely cumbersome. When it interferes with your daily living, then that's when OCD becomes a disorder versus just a trait. Most people have, especially people in healthcare, have like an OCD trait, because they tend to want to be clean and they tend to want to be organized and symmetrical, and nothing wrong with that. I mean, if it interferes with your ability to care for a full complement of patients in a day's time, then yeah, there's a problem. But if you, excuse me, can move through that. God, I don't know why I'm so tired. You can move through that, you should be not really an OCD person. Some treatments, they can use some SSRIs. Again, For OCDs, you're gonna let them do the rituals, but you can contract with them to do the rituals less often. But it's gonna take a longer time to get them to stop the rituals altogether. You may need to go an entire month where they only wash their hands 4 times versus 5 times, so that it becomes a common occurrence for them. Again, that kind of treatment is not something we're gonna see in acute care right off the bat. It's something that's gonna take time in an outpatient setting, and the person has to be willing to work on it with you. Generalized anxiety disorder, that's the big bucket that if they don't know what it is, that's what they call it. And so about 50% of the time, person with GAD worries excessively, and it's for 6 months or more. That's the DSM-5 criteria for it. Person has 3 or more of the following symptoms: amnesia, irritability, muscle tension, fatigue, difficult thinking. People with this disorder are seen usually by family physicians. So if they have anxiety, they may try to put them on an anxiolytic. Luckily, they're starting to get away from some of the Valiums and those kind of things using BoostBar. That's really a good anxiolytic, it's not addicting, and other SSRI antidepressants, namely Paxil is a good one. I think Zoloft. Zoloft is pretty good for anxiety too. PTSD, form of anxiety. The person has experienced a traumatic event, either for severe injury or death to the client or other people. They respond with fear, helplessness, or horror. And so it is an experience of a significant recognizable stressor. And then what happens as a result of that stressor, how they cope and how they deal with that. It includes lots of times with PTSD, it includes the defense mechanism of suppression, where they actually force it down. Then they don't deal with the situation, which is when the flashbacks come. And they have to deal with the situation that's in front of them. It's much more exaggerated, such as if someone has died in a particular room and you were very close to that person and you walk in and you look at that room, you're taken right back to that situation. And it makes you feel the things that you have suppressed down. So some of the things, PTSD, you can educate on it. Some people have no clue what they're experiencing. Usually we see a lot of this in the veteran population, so vets are pretty common and aware of what PTSD, but some aren't. I don't think anybody from 9/11 was familiar with the idea that they might experience PTSD if they were in the Twin Towers. We can teach them how to reduce stress. We can put them in individual counseling or refer them to support groups for people suffering from PTSD. And I'm not going to talk about PTSD because it's somewhere, or I'm sorry, acute stress. It's somewhere between panic disorder, PTSD. So I'm not going to go there. Somatoform disorders. Somatoform disorders are basically where anxiety becomes manifest physically. Okay, so psyche and body, so somatoform. Hysteria, of course, with Freud, he said that we repress and that causes hysteria, and hysteria can turn into stomach aches and other things, and that is a somatoform disorder. The big characteristics of somatoform is physical complaints. They are suggestive of something medical, but there really isn't any proof. Things that cause stress can exacerbate the symptoms, so they get worse as they become more stressed. And symptoms are magnified when it's not underneath of the person's conscious control. So the stress, as it can really exacerbate, it's going to make the symptoms worse. But if they're aware of it and it's under their control, it's not going to make it worse. Somatization disorder, usually what you see is a combination, but usually you see pain disorder. That's the big one, chest pain, versus conversion disorder, which is kind of a somatization disorder on steroids. Conversion disorder attaches to your senses. And it is, you're in a stressful situation and then you can't see or you can't feel or you can't, one of those senses you can experience. Pain disorder, part of somatoform. It's where analgesia just does not control the pain. Usually it's severe. This is the one that I see most commonly. Chest pain is what you're going to see a lot of with this, but their labs are all negative, so it's kind of a rule out. Hypochondria, everybody understands what hypochondria is. They believe it. They firmly believe that they have this disorder. It's a form of somatoform. Body dysmorphic disorder, that's where they see lack of symmetry, and to them it's really exaggerated. So they want surgeries to contract or control what they see is out of order. Usually for body dysmorphic disorder, it happens in adolescence, early adulthood. It's chronic and recurrent. They go from person to person, surgeon to surgeon, doctor to doctor, to get resolution of their perceived problem. Now, malingering is somebody who is just kind of hanging around for the insurance money. That's purposeful. They know what they're doing, as they do in factitious disorder. Factitious disorder includes just Munchausen's by proxy, where there is intentional symptoms to gain attention for themselves. This is the Gypsy Rose case, which we all kind of know about. For malingering factitious disorders, they can control the symptoms, they control the narrative. Whereas with somatoform, they have no control over the symptoms of all. It's their body telling them that they're stressed, but they don't recognize it as stress. They recognize it as usually pain. Some etiology, internalization. Sometimes, I think it was Freud who said that we kind of push everything down, we repress everything, and that can cause somatoform disorder where our body just kind of rebels. And in that, we're rewarded, and as we're rewarded for this, these feelings that we're having, we can get primary gains or secondary gains. Primary gains come from you being sick. So you come into the hospital, you say you have chest pain. You were there 2 weeks ago and last week and you had chest pain. Everything's negative. They work you up again. Everything is still negative. But the problem is you're getting this attention for having this chest pain. That's a primary gain. Okay. Secondary gains come along with, here I have this chest pain and now my kids are flying in from Florida or wherever to come and see me. And so I get to see my children, which is enjoyable. So that is a secondary gain. Okay, so primary gains is what you directly get from being sick. Secondary gains is what you get from other people because you're sick. Okay. That comes with somatoform disorder. We struggle with trying to interpret what somatoform disorder is, and oftentimes people won't believe, and they can be really mean to someone who has this disorder, but you have to realize to them it's real. To them, they're experiencing this pain and it's very real. And you can say, I believe you believe that you have pain. And that's okay. There's just really no biological cause for that. We want to help manage the symptoms. Sometimes antidepressants work. Sometimes that placebo mindset works. You refer them to a pain clinic. They feel like they're getting better treatment, better control because it's more focused on the pain. Whatever works. Therapies do work, individual and group therapies. Some people will go to, like, one of the biggest somatoform that I probably saw would be the sensation, the neuropathy sensations in the hands and the feet. I saw that a lot with people who were working in, when that whole mesothelioma, whatever case study came out, had a lot of people come in and said they were having neuropathic symptoms in their hands and their feet. Well, that was one of the biggest signs and symptoms of exposure to asbestos. And really, maybe they were exposed, but it wasn't to the point of causing neuropathies. You really can't tell with neuropathies. Just like any of these other things, they're subjective experiences. You have to believe what the patient tells you it is. Until you can say, hey, none of our labs are showing this is a problem. You have to believe what they believe. Okay. So nursing diagnosis or nursing process with somatoform disorder. We have to investigate their physical status, obviously, their medical history, how they feel about being sick, how they look, what kind of automatisms they're utilizing, their labile mood or affect. Okay. Thought processes, focus on the symptoms, their sensorium or how they identify things, or intellectual processes, like what is the same thing about a dog and a horse? Okay. How do we insight? We do judgment, we assess insight, how we assess self-concept. You guys should all know these. These should be familiar things for you. Roles and relationships, and then how they look. So self-care. We can give teaching for somatoform disorder, but the big thing is helping them get their emotions out. Sometimes you just have to, you can't linger in it. You can't keep it internalized. You have to bring it out, either write it down or talk about it, but identifying what the feeling is that's causing these symptoms. So we can look at problem-focused coping, or we can look at emotion-focused coping. Either way, I'm not going to ask you the difference between the two, but if you're teaching coping, you want it to work for them. Okay. For somatoform, we really have to focus on what hurts and what do you think is causing that to hurt, because nothing physical is coming up. So what do you think? And you can say that sometimes emotions are so strong, they show up like that. And sometimes people will work with you, and sometimes people will be angry and, say hateful things about you, calling them crazy. Anyway, around it, they have to get it out. How you assess it, the more stress they have, the higher level of exacerbation they're going to experience. So if it's pain syndrome, they say they have a 5 or they have a 10 out of 10. And then you talk for a little bit about things that are making them anxious and you reassess, and now they have a 3 out of 10. That tells you that they were able to let go of some of that anxiety and stress, and that decreased the amount of pain they were experiencing. That's pretty much how you assess somatization disorder. Okay. Yeah. And of course you gotta have to deal with the way you feel about things. So if you're like one of those people that said, you know what, there's nothing wrong with them, they just need to stop, this probably is not a good place for you to be. Yeah, they can't help themselves. They really have no control over their feelings. Okay, now we did not get to the case study in class. I kind of wanted to address that. I wanted us to work a little bit with that. So I'm going to stop sharing my screen. Okay. Okay, we don't want to do that. Well, hang on. I don't know what I'm doing here. Oh, yeah, I have put these things up on YouTube also. If you want to go there, you can. Okay, here we go. Back to modules. Like I said, I wanted to kind of get to this case study. If you want a little more in-depth information on OCD and somatoform, there's a couple more here that speak to these individual things. OCD, it does talk a little bit about hoarding and the particular types of OCD that are out there. You may want to look at this, trying to see the different types that are out there. I don't want to go too much into it, but I do like to ask questions about the different types of OCD. Let's see. Yep, I guess it's not really in here too much. Oh, here we go. Like excoriation, the skin picking, the trichomania, the hair pulling, onchophagia, the nail biting. So I will ask you, not which are self-soothing and which are hoarding and which are reward seeking. I will say which one of these are considered OCD. And I may have, anomania, kleptomania, onchophagia, and then something like compulsive buying or something, I don't know, something like that, but definitely one that is not an OCD. So just kind of keep that in mind. You may want to look at that. Close that up. And let's go to the case study here. I want to go to the case study. Here we go. That, sharing the screen again. And share. All right. Definitely wanted to talk about this case study. You don't have to do this. It's not for points, not for credit, but I've noticed that a lot of you seem to struggle with nursing diagnoses, nursing goal setting, nursing planning, basically the care planning portion of it. So we're going to talk about Maria here. Maria's 24. She's female in college and she's single. She admitted to the hospital after experiencing chest pain, palpitations, shortness of breath, dizziness. Her vitals are stable. EKG comes in, says nothing wrong with her. Emergency thinks it's possibly anxiety, particularly somatoform disorder, and requests further evaluation. Maria says that she feels slightly overwhelmed over the past few months due to academic pressures, family expectations, social challenges. She has never experienced such severe symptoms before and is confused about what triggered her current episode. She really doesn't have any significant health history. She denies drugs and alcohol, has no allergies. She's in her third year of college, majoring in biology, and she is under stress due to impending exams and worries about her future career path. She reports trouble sleeping, headaches, and a sense of being on the edge. She also notes a decrease in appetite and some weight loss over the past few weeks. She does not have a strong social support network, and she feels isolated because her family lives out of state. She looks visibly anxious, fidgeting, hyperventilating. Her speech is fast. She has difficulty focusing on it. She's oriented to person, place, time. She reports feeling scared. Her vital signs are a little hypertensive, little tachy, tachypnic. Temperature's fine though. So respiration's a little labored. She's at 99%. She's basically showing you the fight or flight going on here, with everything else being normal. What kind of nursing diagnosis could we have for her, do you suppose? We look at all of her vital signs. And remember, nursing diagnoses are not medical diagnoses. Nursing diagnoses are something the person's experiencing that we can do something about. Okay, so even anxiety is a medical diagnosis. You can't use that. Hypertension, medical diagnosis. You can't use that. So what is she doing? She's struggling. She's struggling with her sense. She's worried about impending exams and worries about her future career path. So worry, can we do something about worry? Can we do something about ineffective coping? Because she doesn't look like she's coping very well. Yes, we can. So we can say as a nursing diagnosis that she's experiencing ineffective coping related to, and this would be the part that we could do something about. So what's it related to? So we have to ask her, why are these exams scaring her? Is it because she is thinking she's going to fail? Is she concerned about future career path? Is she afraid that there's going to be failure in her future? Now, we can't do anything about her failure, but we can do things about her perception. So we can have ineffective coping related to misperceptions secondary to nursing school or whatever school she's taking, biology. Okay. Secondary can be a medical diagnosis. So if anything is secondary to something, that secondary to part could be a medical diagnosis. So we said ineffective coping related to perception or maladaptive coping, or misperception. Our goal, you're going to say ineffective coping. The goal is going to be Maria will have effective coping. Okay. So you just take the nursing diagnosis, reword it. Maria is going to have effective coping as evidenced by what is she going to do to show you that she has effective coping? Is she going to be stating that her fear or her anxiety now is a 5 out of 10 by the end of the care day? So remember, goals have to be specific and measurable. They have to be realistic. They have to be timed, things like that. So you want to start with the beginning nursing diagnosis. Maria will have effective coping by the end of the care day, as evidenced by stating her perception of fear is a 5 out of 10. That would be a good goal. Your interventions are going to be things you can do to help her have effective coping. So you can teach coping techniques. You can teach her relaxation techniques. You can evaluate her fear or perception of failure, whatever. Those can all be interventions, but we need to know that and why. And then your evaluation is going to go back to your goal. And you're going to say, did Maria have effective coping? Met, not met, partially met. So did she have effective coping as evidenced by rating her pain, or rating her perception 5 out of 10? You set yourself up for 5 out of 10. So if she came back, you can say not met because she rated it at 7 out of 10, or met because she rated it at 3 out of 10, or partially met because she said she rated it at 5 out of 10. I hope you guys understand how to do a care plan. Care plans you're not going to see in practice. It's not going to happen. They're not going to look like this, at least, if you do a care plan. Does that mean that you don't need to know how to do them? No, you do need to know how to do them because they teach you how to think. Okay. So when you go in and you see someone with anxiety, you're going to say, oh, she's anxious. Why is she anxious? Well, it's because of her perception of failure. Okay, this is what I got to do. Without even writing it down, you'll know automatically what to do, why you're doing it, and if it's something that can be measured, do you measure it? Okay, so just learn how to do the process. This is one example of the process. Let's see how you do in clinical. As for me, I am done with anxiety here, and I will upload this to YouTube so that I'm a YouTube star. What you guys need to do is we are having the trauma, domestic violence, etc. quiz coming up next week before our speaker talks. And all of that information on the quiz you will find in this lecture right here. It's been up there for a week and a half now, 2 weeks. Go back, review class 3 recording. Your quiz is over this material. Okay. All right. I hope you enjoyed my airplane. I'll talk to you later. Bye.